many people do you guys have registered for this?
It's just two, just
Okay.
well, a third. I mean, going to something in between, right?
No, I mean, how many people are attending? Is there? do you-
Um, well, in this room it's just the presenters, and so, but it's on YouTube. I'm not sure. I suspect it's gonna be quite a few.
All right, guys, we're live. Esteemed guest speakers, specially invited guests, emergency medicine staff streaming from Jamaica, the Caribbean, and internationally. Other members of the audience, good afternoon. Welcome to the ceremony for the celebration of Emergency Medicine Day and the launch of the Emergency Medicine Week. Under the theme, Innovating Emergency Medicine, Honoring Our Roots, Shaping Our Future. We will begin with a word of prayer from Dr. Eiffel. Are you on, Dr. Eiffel? All right. Not hearing Dr. Eiffel, so just want us to bow our heads in reverence as we ask God to intervene on our prayer. Dear God, just want to thank you for today. Thank you for the amazing day set aside, Emergency Medicine Day, a day where we celebrate what we do to improve patients' lives. Guide and protect this function, Lord. As you know, we have two professors that are willing to share with us what it is that has gone before, what is happening now, and how we can shape the future. Guide and protect everything we do. Help us, Lord, to have no technical difficulties. Help our audience to be thoroughly entertained and informed. These and other mercies we ask in your name. Amen. All right, guys, I had not planned to be speaking so much, but you know, as it goes, if it can go wrong, it will. We are scientists. So today, May 27th, marks a special day on our calendar as emergency physicians. It is designated Emergency Medicine Day. A little bit about this day. On this day, we proudly celebrate the people who make a difference when it matters most, whether you are in the pre-hospital or the hospital setting. May 27th, just in case you did not know, was chosen by the European Society of Emergency Medicine as it marked the day when some visionaries in 1994 came together and signed the Founding Act. The aim was to create a system or a model so every citizen would have a competent and timely response to acute life, organ, and limb-threatening pathology. On this day, the decision makers unite the world population to think and talk about emergency medicine and emergency medical systems. I would like to acknowledge our guest speakers, Professor Philip Levy from Wayne State University, and our very own first professor, Professor of Emergency Medicine, Professor Jean Williams Johnson. Our specially invited guests from the hospital, our colleagues through the length and breadth of Jamaica and the Caribbean, as well as those streaming from the US and the UK, what we call Big Foreign. We appreciate you taking time out to celebrate our special day. At this time, I would like to acknowledge our sponsors, with special mention to Dr. Premanand Singh, who was Herculean in raising funds for the Emergency Medicine Day and the Emergency Medicine Week. Our sponsors are as follows: the Senior Common Room, UWIMONA, Advanced Integrated Systems, CDEC, CariMed, Oswald and Lucille Foundation, Indus Pharma, Dr. Eiffel's Photography, Scotiabank, Grace Kennedy Limited, Indus Pharma, Select Brands, and Massey Distributors Limited. Special thank you to the Emergency Medicine Week Celebrations Committee, Dr. Hudson and Dr. Williamson for their technical expertise today, and Ms. Kadeen Webley and Kiera Roberts for their guidance throughout planning the functions. At this time, enough of me. I'm going to ask our very own head of the Emergency Medicine Division, Dr. Eric Williams, to introduce our first speaker. Over to you, Dr. Williams.
Thank you for that warm welcoming to our division, Dr. Edwards. It's a pleasure for me to introduce Jean. So good afternoon, everyone. Thanks for joining us for this webinar. And special congratulations again to Dr. Edwards for her hard work in organizing this celebratory event. I have been given this opportunity to introduce my mentor, a friend and colleague, Professor Jean Williams Johnson, with whom I've been associated with in varying capacities at the University Hospital as well as UWI for more than 25 years. Jean is a graduate of Westwood High School for Girls, and she attained her MBBS at UWI in 1986. She further went to attain her Master of Science in Emergency Medicine from the UWI in 2000, and then the DM in 2001. In those early days, as some will remember, our first postgrad degree in emergency medicine was a master's done in 3 years and further a year to the DM, a program introduced and guided by none other than Professor Archibald MacDonald. Professor Williams Johnson was among the first batch of 7 who are all now consultants. She became the head of the division of the UHWI in 2003, a position she held for 14 years, and that is a record that will not be broken, Jean. During this interval, she wasted no time in developing academic standards, setting the framework and foundations for various university curricula, and streamlining the emergency department workforce, including securing the post of our first ED administrative manager. She introduced and developed the undergrad clerkship in emergency medicine to the MBBS program in 2004. And with regards to the postgraduates, she was the program director from 2005 to 2021 with an outstanding performance. Along with other faculty members, she turned out over 50 DM graduates from 2005 to 2020. Through the assistance from Professor Philip Levy, who's here with us from Wayne State University, she secured research opportunities for a number of program residents, an exposure that has been well received up to today. Other achievements, not necessarily in chronological order, include completing her diploma in medical education at the University of Dundee in 2019, also being awarded a Fulbright Scholarship in 2010, serving as the university examiner for the DM Emergency Medicine from 2015 to 2021, and also being the Deputy Dean of Graduate Studies in the Faculty of Medical Sciences, UWI Mona, from 2021 to 2023. She pioneered the introduction of the Diploma in Emergency Medicine in Mona in 2021, a program which was started in Trinidad, and Dr. Jason Eiffel now coordinates that program. She has over 48 publications, including 2 book chapters on sickle cell disease in the Tintinelli Emergency Medicine 8th and 9th edition. Her published work has attained over 4,687 citations. Ladies and gentlemen, members, without much ado, join me in welcoming Professor William Johnson, who will speak about emergency medicine in the region, a look at the past and how far we have come and what is in store for the future. Thank you. Welcome, Professor.
Thank you very much, Dr. Williams. I appreciate you and saying those kind words. And it is indeed a pleasure for me to be invited to give a talk today. And I think Dr. Williams forgot to say that I'm retired from the University of the West Indies. So thank you all for being here, and we'll go into the talk. We're talking about the evolution of emergency medicine in the region. I said, here we are, and what's next? So the discussion about emergency medicine, how it developed, probably was because of the regional links that occurred because of the postgraduate program that we had in emergency medicine. We had the program beginning in Barbados in 1990, Queen Elizabeth Hospital, and then moved to Mona in 1997, Trinidad 2005, and the Bahamas 2007. So we recognize that evolution occurred because of the links that we were able to attain. And like Dr. Williams, I would like to also congratulate Dr. Romaine Edwards for spearheading this celebratory event. Of course, more things to come in June. And congratulations, Dr. Edwards, you have really taken the mantle and run with it, as we say in Jamaica. So we're going to have a look at some of the challenges, some of the triumphs, and look at the future ambitions or future hopes and plans for emergency medicine. I'm going to show a little video and just say that there's a copyright disclaimer, so it's okay to use it. I'm not infringing anything.
Morning, Jack. What are you doing here? Working. And if you jump on my shift, that's just rude, man. Hope I'm never one of your patients. Makes two of us, my friend. Hey, D, what's the good word? 52 in the waiting room, and it's not even 7. This mad. It's like a little challenge every now and then. Over. I'm so happy to be here. Talk to me at the end of the day. Where's that? Suction. Let's do the down. To the pit. Let's go save some lives. 80, 14. You've lost a lot of blood. You need to go to surgery right away. Who's gonna die?
Not now that I'm here. I'm in.
Good. Well done.
That's awesome.
Is it always this busy?
No, it's not this year. They're us. Here.
Welcome. Ready to call this? Thousand people die every day in the world. There you go. More morphine. I'm going to stop the bleeding. You're going to accept it. Find balance. Balance.
Okay. So the challenges that we face, just thought I'd show that you thought I found the show quite intriguing, and if you haven't had a look at it, have a look. It's on HBO Max. So the challenges that we have faced regionally have to do with things like the disease burden in terms of the patients we care for. There's a high prevalence of non-communicable diseases and their end-stage presentations, the stroke, the myocardial infarction as a result of things like diabetes and high blood pressure. High prevalence of infectious diseases in terms of dengue, and we have to be always on the alert and prepared to manage these patients. Of course, limited resources remain a challenge. There are insufficient funds and insufficient personnel. And the pre-hospital services for most of the region, they tend to be underfunded. There's a big exit block in terms of patients moving out of the emergency department. Most of our emergency departments are overcrowded because there are not enough beds to take them into the hospital. And of course, that comes with the attendant need for staffing. The region is plagued by natural disasters. We have hurricanes every year. Hurricane season is just about to start, 1st of June until the end of November. We have challenges with earthquakes, floods, and all of these strain our emergency services and strain our ability to support patients who come to us for care. Of course, geographic isolation is also a challenge, especially in the Bahamas, where they have islands which tend to be remote from the main hospitals. So there's always a need to move these patients whenever they have health issues. But we have triumphs, regional collaboration, which I will go into. And of course, a lot of that relates to training and education that has been disseminated. So as you would recognize, the University Hospital of the West Indies tends to be the hub of the development of emergency medicine in Jamaica. We are one of 23 public hospitals on the island. We have an emergency room, and we tend to be the main teaching hospitals. 19 of the other hospitals do have emergency rooms, and I'm happy to say that DM graduates now populate most of these hospitals. The delivery of healthcare in Jamaica is divided up in terms of regions. The Western region, we have physicians in Savlamar, Cornwall Regional Hospital. Southern region, doctors in Mandeville, Maypen, and Lionel Town. The Northeastern region, we have doctors at St. Anne's Bay and Anotta Bay. And of course, the South region, we now have a doctor in Linstead. Spanish Town has quite a few emergency medicine consultants, and of course, University Hospital. And happily, we also have doctors trained in emergency medicine populating our private emergency rooms. I think Dr. Colonel Espinosa spearheaded that at the Medical Associates Hospital. And we now also have Dr. Janelle Hugh in that institution. And at Andrews, we have Dr. Miosotti Johnson. So we are spreading. In the past, and Dr. Williams told I was head from 2003, donations were the order of the day. My friends used to run when they see me coming because they figure we're coming to beg them something. But happily, we were supported by the Scotiabank Centennial. It was their centennial, and they decided to give us an extension in the old casualty to form the accident and emergency unit. And this was around about 1999. And I put a picture here of Mrs. Jolene Griffiths Irvin. She was one of our benefactors from the Scotiabank unit. She was able to allow us to build and expand, and they also used to support us with funding each year. But unfortunately, because of changes in the financial system, we lost that support. We're still branded for what it's worth. I mean, they did build the unit, so there's discussion about how we'll take that forward. In the past, we used to have patients walking straight into the A&E, asking for directions. They wanted to go into the hospital to find persons who were admitted, or they wanted to find clinics. We recognized that there was a need for a customer service center. So we lobbied the Chase Fund, and they were able to give us the customer service center that is there at the front of the hospital now. In the past, triage was a challenge. It was kind of open done, and there was no privacy, no bathroom close by for the patients. And the guidelines in terms of triage, those were very vague. And as a challenge, some patients were often down triaged, and we would miss the really ill patients. So the Chase Fund again came to our rescue and donated the triage rooms in 2013. We have 2 triage rooms, and so there's privacy there. And this is on the side entrance to the department. We have 2 main entrances. Patients register first, and then go to triage, and there's a private bathroom between the 2 rooms, which is really useful now that it's there. We have to congratulate Dr. Simone French, who introduced the Emergency Severity Index system to the department, who took it over in 2007, and she also spearheaded this as the national system that's using the islands. All of our emergency rooms use the ASI system as of 2016. The triage ambulance entrance, though, patients are taken into the main A&E and triaged there. We also asked for support from the Jamaica Medical Doctors Association. I think that's Dr. Shane Alexis, who was head at the time, along with our own Dr. Romaine Edwards. When we had a formal opening, we would have patients needing some privacy, or we would need some privacy to tell patients what was happening to the families and so on. There's no place. And patients used to come in and roll on the ground kind of thing. It wasn't very disheartening. So happily, we were able to get this blue room donated. So the staffing in the emergency department consists of emergency consultants. We started out with 3 and now we have 9 consultants. We had 3 post DM and 4 in all, really. And now we have 9. We have a new category of staff called emergency room technicians who are able to help with things like putting on plasters, they learn CPR. We have our patient care advocates who advocate for the patient and help us whenever, especially in situations where we need to help to get the patients moving. We, of course, have the emergency medicine program, so we have residents in training, which I'll tell you about. And we have our senior house officers. These are doctors who are in the 2nd year post finishing their undergrad degrees. We have nurses, some of them trained in emergency medicine. And of course, we have non-specialist nurses as well. In the past, the department used to look really nice and well controlled. We used to move patients out, no challenges in terms of exit blocks. Unfortunately, no, overcrowding is quite a challenge. And sometimes when we go to work, there's hardly any place to walk, and it's there, and we'll see how the new staff will deal with that, or the present staff. Maybe I'm retired. So in terms of training, we have the postgraduate programs, the DM in Emergency Medicine, introduced by Professor McDonald in 1997, the postgraduate diploma in 2021. Undergraduate programs, our 4th year clerkship was introduced in Mono in 2004. The medical students spent 5 weeks with us, and this clerkship is now being run by Dr. Rhonda Hudson since 2010, I think, or 2012, and she's doing an excellent job. We're always getting very high recommendations. I'll say a little bit more about that. And our certificate in emergency nursing, or CN course, was introduced in 1995. No talk on emergency medicine would be complete if we did not talk about Professor Archibald McDonald, who made emergency medicine available to the Mono campus in Jamaica. The first cohort of 7 candidates began in 1997, and in 2021, the first set of DM graduates emerged, and the tone for emergency medicine in the island was set. So Professor McDonald gave us this edict when we started the program. He says, do not go where the path may lead, go instead where there's no path and leave a trail. And we hope that we have been doing this and that he'd be rightly happy. So some of the challenges that we faced in terms of the postgrad program had to do with research. I'm going to tell a little bit more about the program structure when we look at the Barbados contribution, because in 2006, research became a mandatory part of training. We had difficulty with accessing records, lack of research assistance. We tried to get some in, Dr. French can remember that, but that's something that we may have to revisit if we can find the funds. And of course, what happened in 2006, I don't know, Professor Levy, who is our next speaker, will remember he and his friend, James Saddock, came up to meet us here at Mona. And it was, I think, the year we had a hurricane. So, I mean, they were really brave to travel up from, I think it was in St. Elizabeth. And he recognized, he asked, what do we need? We said we need some help with research. And he went and wrote grants. So we had 11 residents trained. These residents went up and spent a month with him at the Wayne State University, Detroit Receiving Hospital. And this has led to various publications. And Professor Levy has also been an external examiner, and he brought us our first ultrasound machine and introduced us to ultrasound, which Dr. French has certainly taken the mantle where that is concerned. I won't say too much about him because I know Dr. French will introduce him, but we just wanted to acknowledge his help. And so we have had various successes in terms of research, and our team, we were involved in the landmark CRASH 2 trial. It's a clinical trial, and now tranexamic acid is sort of a standard of care in these patients, and we are really happy that we were able to participate. We also have other triumphs, not just our challenges. We have garnered a lot of respect for the specialty from our colleagues. I remember when I just started emergency medicine, one of my classmates from medical school days asked me, does emergency medicine have its own journal kind of thing? But no, certainly in terms of the hospital, people will ask us to do ultrasounds for them. And one of my colleagues was sharing that she was invited to sedate a patient who had a complex laceration that a surgical team needed to repair. We have had good development in terms of a curriculum, more to go, but certainly in terms of how the exams are being delivered now, we have progressed. The research output has increased. We have over 70 papers between the faculty, and 2 papers were actually presented at the CARFA conference this year, of which we are very happy about that. Talk a bit about the triumph of our consultants and staff. As I said before, Dr. French has led the way in ultrasound. She's actually formally trained in sonography in the Michener Institute in Canada and the School of Medical Radiation Technology here in Jamaica. Our Dr. Rhonda Hudson is a sexual assault expert examiner and trainer, and I know she visits various Caribbean islands sharing this knowledge with the doctors, and we are extremely proud of this achievement. And as I said before, she's in charge of our undergrad program. Dr. Eric Williams and Dr. Shubha Dasgupta, important in trauma management, pre-hospital training, and Eric has been our head of department for the last 3 years. Happily, we also have an interest in fellowship training. Dr. Nadia Thompson-Noel has done her fellowships in pediatric emergency medicine, which is an area that we really are happy for, since we do need that kind of expertise in the department, and simulation medicine, something our faculty dean has been advocating for as well. Dr. Pimanand Singh has been with us from the start. He was my deputy director back in 2003, and he has specialty training in sports medicine, and he has received national honors from the country. He has a commander class CD, that's what they call it, because of his work in particular with netball, and we're happy to have him in the unit as well. In terms of the postgraduate program, let's talk about the diploma program, which started in 2021. We have had about 21 graduates. Program, as Dr. Williams told us, started in Trinidad, and Dr. Jason Eiffel has taken the mantle, and he's really been doing well, another one of our consultants in the unit. So since the inception of the program with Professor McDonald, the first graduates in 2001, and up to now, we have had over 60 people graduate from the program, and some of our graduates in Jamaica are in leadership positions. Our Chief Medical Officer, Dr. Jacqueline Biseso McKenzie, and we have directors of emergency care who work in the Ministry of Health, Dr. Nicole Dawkins Wright and Dr. Janice Miller, and yours truly is a registrar of the Medical Council. In terms of our training programs, as I mentioned before, we have a 5-week rotation for the medical students where they do activities, procedures, and Dr. Hudson has introduced new things to the clerkship, including a debates afternoon, which has been very well received. The students really enjoy and learn from this activity. Our emergency nursing course began in 1995. Dr. Hilda Ming was the first director, and this was taken up by Miss Blondell Walker, who left us a couple of years ago. I know Miss Lorna Thompson is leading the charge for the emergency nursing course. And we actually have 7 students in the current cohort. It's been over 20 years, going on 20 years. So as you can imagine, we graduate between 10 to 15 students each year. So we have over 200 nurses who have done this program. Fortunately, they are so very well trained and well equipped that we lose them to greener pastures. But the program continues and we're happy for that. So moving forward in terms of Jamaica and Mona, we're looking forward to improvement in pre-hospital care, disaster medicine, toxicology, and trauma management, and improvement, of course, in our emergency medicine, medical service, and our first responders. We look forward to continued investment in the infrastructure. We want to see an upgrade in the emergency department and the facilities in the hospital, where we have an increase in inpatient beds to mitigate against overcrowding that happens for us. I want to see a more efficient discharge process. And just a quick slide to show you who have been the heads of departments since we took over from PUFMAC in 2003. So it is a regional discussion. So I reached out to our colleagues in Barbados, Trinidad, and the Bahamas for them to give us an overview as to what has been happening there. The program began in the region in Barbados, actually in 1990. It was founded by Dr. Raina Naidu, who I think lives in the US now, Professor Lenworth Jacobs, Professor Sir Errol Waldron, all in Barbados. The program was based on the family medicine system, and Professor Lenworth Jacobs was actually one of the first external examiners that we had. Matter of fact, I think he was the examiner of the first cohort of graduates from the program. The Barbados program began with 4 residents. 3 graduated with the MSc in 1993, 2 graduated with the DM in 1995, and they've had a total of 44 graduates since inception. They currently have 11 persons in the program. Again, no talk in terms of emergency medicine Barbados could be complete without mentioning Drs. Harold Watson and Reginald King, who have been stalwarts of the program, training residents as they face the various challenges. They began with 1 lecturer in 1990, 2 lecturers in 2014. 1 associate lecturer was introduced in 1990, and now they have 5 associate lecturers. Again, we spoke about the 3-year program, and after the research component was made mandatory, we split into two components. The first 2 years would be mainly the application of applied basic sciences, and then the part 2 will be clinical, when the research project would have to be submitted. Rotations are listed here. We said the residents would spend a few months to weeks in the various areas, and this is the basis for the program in Jamaica, Trinidad, and the Bahamas. It's one university out of West Indies, so the emergency medicine program is similar across the fields, except for some areas like the emergency ambulance service, which tends to be a child of Barbados. There has been successes in Barbados. Resuscitation care has grown, expansion of the hospital, and expansion of advanced care in the emergency department to include invasive line placement, use of pacing, and ultrasound. Of interest in Barbados in particular, there has been a development of private emergency care facilities led by DM graduates. And Dr. Brian Charles in the image is actually one of the directors of the Medical Protection Society, which is important for delivering medical protection and malpractice insurance to our physicians. Not just emergency medicine, but he is emergency medicine trained, and I think he's involved in one of these private facilities as well. A success in Barbados, as we said, was the development of the emergency ambulance service, and here's Dr. David Bayo, our emergency medicine physician, who is responsible for this. They also list among the successes a field hospital and a wide involvement of graduates of the program in teaching residents, even if they're not official faculty. And they have had persons do fellowship in critical care, disaster medicine, pre-hospital and forensic medicine. Challenges in Barbados. The program is under threat because of the failings of the hospital. Sorry about that, but that seems universal. Long waiting times, poor public perception. Finances affect the growth of the program. They aren't able to employ as much lecturers as they would like, and that also results into a limitation in the number of residents who can be accepted in the program. And we like to expose our residents to first world standard of care and equipment. So it's important that they be allowed to go overseas to get this exposure, as was facilitated by Dr. Levy. A nice picture of them examiners in Barbados. Barbados has a very nice exam center. We're trying to convince them that we should have exams there all the time, but that is for discussion, I suppose. Trinidad and Tobago in 2005, that's when the program started. Dr. Ian Sammy returned to start the emergency medicine program in that island. He began with the diploma program, the master's, and the DM in emergency medicine. In 2009, Joan Paul returned after specializing in pediatric emergency medicine, and so she and Dr. Sammy were the two lecturers in the program. Of importance, Dr. Paul now serves as our university examiner. So in 2012, Dr. Sammy decided that he needed to do his PhD, and so he returned to the UK. And apart from Dr. Paul, Dr. Shamir Ramlakan joined for 2 years. In 2017, Dr. Arvind Ramnarayan joined the team in 2017 as well, and Arvind is now the program coordinator for the DM in emergency medicine on the Trinidad and Tobago campus. Dr. Salim Barachia joined the team in 2022, quite industrious young man, quite enthusiastic, and I think it augurs well for the program to have him on board. The first set of MSc graduates from Trinidad was in 2007, first set of DM graduates in 2008. So, and as of 2025, they have 195 diploma emergency medicine graduates, 35 DM graduates, and 6 MSc graduates. The MSc program was discontinued after these first 6 graduates, and the focus has been just on the diploma and the DM in Trinidad. Trinidad has 5 major hospitals, and they have 10 district facilities which have emergency departments. And happily, each department is headed by a doctor who is DM trained and qualified. And most of the senior medical officers in these hospitals are also DM trained. Happily, the peripheral EDs have diploma persons as registrars, as doctors working on the floor. Some of the graduates from the Trinidad and Tobago program have actually migrated to Australia, UK, and Canada. Some of the diploma graduates have also migrated, but the diploma has assisted in getting them into postgraduate training programs. Interestingly, in Trinidad, one of the graduates has gone to do a subspecialty in critical care, one has done toxicology, and 8 decided to do their MBAs post-DM. The challenges that they have in Trinidad have to do with persons who graduate from the UK with a non-exit type of degree and call themselves specialists in the area, and they come to the island trying to get a job as a consultant. So the medical board in Trinidad is trying to sort that out because it's a challenge for them. And of course, the emergency departments are understaffed, under-resourced, and crowded. And so the emergency medicine persons are prone to burnout. The list as a triumphs in Trinidad that the diploma program has been successful because 1/3 of these graduates go on to the DM program. The rest either stay in emergency medicine or they may do family medicine and get dual diplomas. And every peripheral emergency department is manned by multiple diploma graduates. Another triumph is their vibrant Trinidad and Tobago Medical Association, Emergency Medicine Association, which advocates for continued education and representation in the various levels. They have a consultant-led pediatric emergency department, and this was a first for the Caribbean, first that we had somebody trained in pediatric emergency medicine working in the island. And they have full coverage And some of the staff who work there also have fellowship training, apart from the first person who was Dr. John Paul. Just I'd like you to know that part of the triumphs that they list for Trinidad include an onion system, where as each resident is trained, they give back and teach those coming up. So even if they're not employed as faculty, they are very active in training, and it provides a large base for them, especially for the diploma exams. Of importance, Dr. Ian Sammy was the first person in the Caribbean who has done a PhD in emergency medicine. Remember, he went to the UK and did this, and this has proved to be a large boost for research guidance. There's a plan to start in terms of the vision and the next steps for Trinidad. They want to start up diplomas in geriatric emergency medicine and pediatric emergency medicine, with Dr. Sammy is going to lead that charge for geriatric emergency medicine. Of a recognized need or interest is a need for graduates who leave the Caribbean to be able to go to the US, UK, and Australia without having to repeat exams. That has been a challenge for quite a while. I'm not so sure how easy it is going to be to circumvent that. And of course, we have to give us a picture of some of the DM examiners. I think this was the last exam in 2023, 2023 in Jamaica, and I'm sure you're able to recognize some of the persons smiling down at you here. So the Bahamas, this is our newbie group. It was introduced in 2008 with oversight from the Mona faculty. Dr. Colin Bullard was the first program coordinator. So Bullard has taken off since 2014 to more greener pastures. We won't fault him for that. And they started the program with 3 associate lecturers, Dr. Michelle Sweeting, Dr. Sarah Faraday, and Dr. Carolyn Burnett Garraway, who at one stage was also medical chief of staff of the hospital in the Bahamas. I think Michelle remains on faculty, and Dr. Friday is probably off to greener pastures as well. The Bahamas started with 4 residents, all of whom are active in the program, apart from Dr. Cordelia Nairn of blessed memory, who we lost a couple of years ago. So Dr. Raquel Davis, Dr. Krista Wells, and Dr. Pavia Davis. Dr. Wells was the program coordinator for 2014 to 2023, and Dr. Davis Mackenzie is now the current coordinator. And they have 12 residents enrolled in the program currently. And happily, 15 residents have completed the program and serve as associate lecturers. The challenges that the Bahamas faculty would want us to share is that it's a small faculty consisting of just 2 clinical tutors and associate lecturers. So the persons who are listed as part of the faculty are doing so out of the kindness of their heart and the love for emergency medicine. But there are no full-time lecturers, and so it's difficult for them to balance clinical versus academic responsibilities. Out of some of the challenges that the Bahamas group shared is that there's limited access to the online platform for the university, as there's only 1 lecturer with an ID number, which of course, is a challenge. Each lecturer can only supervise a maximum of 2 residents, so they can only take a small number of residents each year. As with the other departments, overcrowding continues to plague us with the boarding of admitted patients. The department has been under renovation since 2022, and it continues to current time. Hopefully, it should soon be completed. Some of the triumphs, the department has introduced a robust doctor-to-nurse triage system, and what they have found is that the amount of patients that they have seen has decreased from 39% to 18% in ASI levels 4 and 5. They list as a triumph the fact that they have been able to host exams. With the DM program, we rotate through various campuses, and Bahamas being the newbie, it was quite an achievement for them to host us back in 2017, 2019. In 2021, it was online, and then in 2024, they held the last diet of the exam. Here's a nice picture. Just put that in to show you our men of emergency medicine, how mature they look, right? And this was at one of our post-exam meetings. The graduates of the program in the Bahamas are back giving their service as lecturers, and they've been writing exam questions. Disaster management is a big thing for them. They were able to give a presentation at the World Association for Disaster Medicine and CARFA. And Dr. Latoya Starr has happily completed training in disaster medicine. We have to give them kudos because the Bahamas faculty were the ones to introduce the concept of the Emergency Medicine Week back in 2024. And it's a nice flyer that they have sent of the various activities that took place, which we saw and now decided to inculcate here at Mono. Future ambitions encourage residents to pursue subspecialties and develop a center of excellence in disaster management in the Bahamas, which we expect should serve the rest of the Caribbean. And these were the examiners in 2024. And I'm sure Prof. Levy recognizes Prof. Deborah Dirks, who was one of our he's one of our external exams. I think she's coming again this year. Moving forward, goals for the future in terms of the region, of course, increasing workforce, more subspecialty development, improve pre-hospital care and in-hospital care, of course, to get rid of our exit block, to improve data collection and research, and of course, we must continue to strengthen regional collaboration and partnerships. Artificial intelligence is with us. I don't think we're gonna, we can't run away from it. And in terms of emergency room, there are things that we may be able to find it useful in terms of predicting patients who are high risk and forecasting outcomes of patients who we have to be sort of more attentive with. And of course, in terms of treatment and so on, the AI has use there. So the evolution continues. The University of West Indies has mandated that all our degrees, our persons who are doctors who are products of the training must be trained for the region. And certainly now our graduates exist in Jamaica, Barbados, the Bahamas, Trinidad and Tobago, the Cayman Islands, the Turks and Caicos Islands, the British Virgin Islands, Bermuda and Antigua. And so we think that we are on the right track. And I thank you so much for listening. And I hand you over to our next speaker.
Oh, thank you very much, Professor Williams-Johnson, for your engaging and historical and informative presentation. Just want to ask persons in the audience for you to put your comments or your questions in the chat. And we have our able technical team here. They will ensure that the speakers answer your questions if you have any, okay? All right, so at this time, we're going to recognize some local, regional, and international contributors to emergency medicine via an interactive talk. But while we do that, I'm just going to remind you of the other activities that we have for our EM week. Just to say that, well, first of all, let me tell you how, I think Professor Williams-Johnson gave it away. 2024, we went to Bahamas to examinations and we were well hosted, by the way. I'd go back any day, right? They really pulled out all the stops for us. And the day before the exam, no, the day of the exam, when they dropped us off, I was actually looking at the poster. And then Dr. French came on and said, Dr. Edwards, what is that? And I said, Bahamas celebrated Emergency Medicine Week. And she said, wow, we should have that. And when she said that to me, I am not sure she didn't think that I was going to follow through, but I came back to Jamaica. And of course, my first thing was to do my homework. So I called up Dr. Wells and I said, hey, Dr. Wells, tell me about your Emergency Medicine Week that you just had. And she detailed me and I took good notes. And here we are, I pitched it to Dr. Williams, our head, and he was excited. I pitched it to the other consultants because, as you know, ideas will come and ideas will go, but you need people to follow through. And so all the consultants have taken a piece, all the nurses, all the ERTs, the emergency room technicians, all the phlebotomists. And when you have persons working together in part and we're pulling and we're going in the same direction, what you have is a production, right? A flawless one too. And so I'd just like to say thank you to my colleagues for entertaining and carrying through on our Emergency Medicine Week. And so, unfortunately, we are hosting. Sure, you can go ahead. Unfortunately, we are hosting, well, not unfortunately, we are hosting exam. And so we could not, in good conscience, put Emergency Medicine Week before exam because we're thinking of the residents and we want to ensure that they participate, or as we say on campus, full-ticipate in all the activities. And so we have decided that instead of having Emergency Medicine Week this week, which is before their exam, we're going to have the week of activities after the exam, June 8th to June 14th. So I'm just inviting you to the other activities. On the Sunday, June 8th, 2025, we will be having our church service, and that is at the Dominion Center, where our very own resident pastor, Dr. Eiffel, will guide us through the service. We're going to be their invited guests. So we're asking all persons who are possible to come out with us to celebrate and, you know, have prayer and reverence on that day. So that is Sunday, June 8th, 2025 at the Dominion Center. They start at 11 o'clock. On the Monday, we have the expo. Now, I know Dr. French must be saying, Dr. Edwards, I have a lot of things to do. I have the exam to plan. I am the DM coordinator, and you have given me an expo. But what she has is, she has a team. As she said, her team keeps growing. There's Nurse Blake, Miss Robinson, who is our public relations officer for the hospital, Dr. Morgan Williams, to name a few, right? I'm sure she has expanded on her committee to ensure that they pull off showing and showcasing what we do in the emergency department in an expo, right? So we're inviting you to that. It's on the Monday. It will start at 9 and end at 2 p.m. We plan to have booths and we have sponsors that, you know, will help us to showcase what we do. So the nurses, the doctors, the emergency room technicians, the phlebotomists, the patient care assistants, we're all going to show what it is that we do to help the patient when they come for acute life, organ, and limb threats. On the Tuesday, we're going to have a sexual assault examination webinar, and we have as our speaker, Dr. Latanya Arthur, and she is one of the proteges of Dr. Rhonda Hudson. I know Dr. Hudson is about to slap me. And we're gonna have a talk on just the basics, just the essentials, what it is that as physicians we need to do when we encounter a sexual assault victim. And I am very excited for that talk. It has 2 CME credit hours attached to it. And so we look forward to your full participation. On the Wednesday morning, we're going to have a quiz. We have divided the emergency medicine division into 3 teams. So team A is named after Professor Archibald MacDonald. Team B is named after Sister Clary, who was one of the sisters who was you know, major influence in the department. And the team C, which is Team Dawkins, that's my team, the winning team, I hope. And we are going to battle in quiz based on emergency medicine knowledge, current information, and history of emergency medicine. On the evening, we're going to have a lime at the SCR, and we look forward to that because, as you know, emergency medicine division is a very tense area. You know, work is very stressful. And so, you know, we're going to let down our hairs, our wigs, etc. And we're going to enjoy a nice lime at the SCR on the Wednesday, courtesy of Dr. Rhonda Hudson, Dr. Thompson Newell, along with Dr. Premanand Singh. On the Thursday, we're going to have netball and football competitions based on the same 3 houses. And this is guided by Sister Murphy Nedrick, Dr. Carlton Miller, and ERT Brown. They are in charge to make sure that we have a successful competition. And I won't say, but, you know, I'm hoping the best team win, and I'm hoping that team is Team C. You don't have to guess which team I belong to. And then on the Friday, we're going to have a dinner at the Alhambra Inn. It starts at 7 p.m. Tickets are available. It's $5,000 before the 31st of May and $6,000 afterwards. Professor Williams Johnson has kindly offered to spearhead that team for me, and she is actually doing a great job. I can say that a lot of the time it was Professor Williams Johnson guiding me to say, let us keep our timelines. And so that function, we're going to also have a forum that Dr. Hudson and Dr. Thompson Newell, they are showcasing lots of, challenges as well as triumphs in emergency medicine. They have a whole panel that is going to detail us on that. So I'm looking forward because, sometimes at UE, we may think we have the solution, but then we find out that there are some other EDs that have some other workable solutions that can apply to us. And then on the Saturday morning, we will end with a walkathon / road race, where again, team A, B, and C will compete, but we can have team unattached, meaning we can have other persons that will come and we are going to walk and we're going to run together. It's from 6 a.m. to 8:30 a.m. A 3K, UE Ring Road and the Hospital Ring Road. All right. So we're inviting persons to come out and get physical. As medical practitioners, we tend to say, do as I say. And so we're trying to also do as we tell you to do, the audience, that is. We're going to make sure that we have some physical activity built into this week of activities that we are celebrating emergency medicine. All right. Now, I hope you were paying attention because I'm going to quickly go through the local, regional, and international contributors. And this time, I'm going to also ensure that we win some prizes, right? Okay. All right, so starting with the question number 1. This person is considered the father of emergency medicine. Who is he? So we're going to ask you to type your answers in the YouTube chat, and then the person who gets the most answers correct will win a basket from Massey Distributors, soon to be called Acado Distributors Limited. And then the second basket is for a Massey directed question at the end. All right, so we're going to ask you to type your answers in the chat. Who is this person that is considered as the father of emergency medicine? Any takers? Any takers so far? All right, so we're gonna give you another 5 seconds and then we're gonna give you the answer. You have to tell me. Okay. So my technical team is telling me that because of the delay, I have to await for 45 seconds until you guys. All right, this question seems like it's bowling a few people. So let me give you the answer. So this is Dominique Jean Baron Larrey. He was a French surgeon and soldier. He served in the French Revolutionary and Napoleonic Wars. He was an innovator in battlefield medicine and triage. He invented the flying ambulance. So what he noted was that during the war, you would have French flying artillery maneuvering through the battlefield. And he thought to himself, I need to get a device that would carry the injured soldiers as fast through the battlefield. And he was credited with inventing the flying ambulance. And he's often thought of as the godfather of emergency medicine, right? Or the father, sorry, of emergency medicine. All right, moving on to question 2. I don't think anybody got that one. Which year was emergency medicine made a specialty in the United States of America? A, 1965, B, 1930, C, 1970, D, 1979, E, 1980. So type your answers in the chat and then we will see who will win that big basket from Massey Distributors, soon to be called Acado Distributors Limited, ACADO. I'm hoping I'm pronouncing it correctly. So one person got question 1 correct. So we'll see if that person will add to the tally. All right. Okay, so which year was emergency medicine made a specialty in the United States of America? Is it A, 1965, B, 1930, C, 1970, D, 1979, or E, 1980? Tell me to go ahead. Go ahead. All right. So the answer is D, 1979. By a historic vote by the American Board of Medical Specialties, emergency medicine became recognized as a medical specialty in the US. 1979. So we're a very young specialty. In fact, you will find that persons will tell you, for example, I traveled to the Dominican Republic and they don't have a program there and they are very limited, right? When you travel, when you go to the emergency department there, especially the public emergency department, they still rely, they actually have, medical students, but the doctors who work there, they rely heavily on the other specialties, and the other doctors have to come down to do basic investigations. So they assess call whichever specialty and they come down and investigate the patient. I found that extremely strange. All right, question number 3. Who is this professor and surgeon? What was he credited for in the emergency medicine in the Caribbean? So who is this professor and surgeon? What was he credited for in emergency medicine in the Caribbean? I'm sure Professor William Johnson is, if you are listening to her presentation, then that basket is almost yours. Hint, hint, he was a former principal and former dean of medical sciences. All right, we're seeing some correct answers, some incorrect answers. All right, so we're gonna move on. The answer is 1997, via Professor Archibald MacDonald, the DM Emergency Medicine Program became available at the Mona campus in Jamaica. So he was credited in being one of the pioneers in starting the emergency medicine postgraduate program at the Mona campus. All right, next question. How many enrollees or doctors were there in the first DM emergency medicine program in the Mona campus? Is it A, 4 doctors, B, 6 doctors, C, 5 doctors, D, 3 doctors, E, 7 doctors? Come on, guys. Nice big basket from Massey Distributors, soon to be called Arcado Distributors Limited. Let us see those answers. Is it A, 4, B, 6, C, 5, D, 3, or E, 7 doctors that were initially enrolled in the first DM emergency medicine program at the Mona campus? That was in 1997. All right, so my technical team, can I go ahead? All right, so those of you who said E, you are correct. There were 7 doctors: Dr. Rhonda Hudson, Dr. Simone French, Professor Jean Williams Johnson, Dr. Elizabeth McLaughlin, Dr. Hugh Wong, Dr. Eric Williams, and Dr. Nigel Booth, who is now in Cayman. All right, so there were 7 doctors enrolled in the first DM emergency medicine program in Jamaica in 1997. All right, we're doing well. The basket is on its way out, I see. All right, just a few more questions. Prior to the establishment of the emergency medicine program at UWI Mona, which physician was in charge of casualty at the University Hospital of the West Indies, Mona? Was it A, Professor Archibald MacDonald, B, Dr. Charlton Colley, C, Professor Kenneth Vaughan, D, Dr. Premanand Singh, or E, Professor Peter Fletcher? Which physician was in charge of casualty at the University Hospital of the West Indies prior to the DM emergency medicine program, when they had the merger between A&E and casualty? Is it A, Professor Archibald MacDonald, B, Dr. Charlton Colley, C, Professor Kenneth Vaughan, D, Dr. Premanand Singh, or E, Professor Peter Fletcher? This one seems to be bowling us. Okay. All right, as we move along, the answer is, if you chose D, you're correct. Prior to the establishment of the emergency medicine program, which physician was in charge of the casualty unit at the University Hospital of the West Indies? The answer is D, Dr. Premanand Singh. All right, we're warming up. All right, which Caribbean territory celebrated the first Emergency Medicine Week and in which year? Is it A, Barbados, B, Trinidad and Tobago, C, Jamaica, D, Bahamas, E, Dominican Republic? If you guys were listening, this is an easy one. Which Caribbean territory celebrated the first Emergency Medicine Week and in which year? So we're looking forward to the right answers. Quick fingers, quick fingers. All right. I see you guys were listening intently. Do we have a leader for that basket? Remember, you have to get maximum. So the person with the maximum number of correct answers will get the basket. Courtesy of Massey Distributors Limited and their excitable and exciting rep, Miss Natalie Robinson, who wants me to tell you that they're going to be named Acado Limited, Acado Distributors Limited. All right, guys. If you said Bahamas, you are correct. The Bahamas, they were the first territory to celebrate Emergency Medicine Week last year, 2024. I saw the flyer. Dr. French got excited. She said, Dr. Edwards, we need to do this. And here we are. When was the DM Emergency Medicine Program started in Barbados? Was it A, 1979, B, 1980, C, 1987, D, 1989, or E, 1990? So guys, quick fingers. A, 1979, B, 1980, C, 1987, D, 1989, or E, 1990? We just have about 3 more questions, and then you get to win that lovely basket if you have the most answers, and then we have a 1 question from Massey Distributors Limited. My technical team tells me that we have a front runner. All right. When was the DM Emergency Medicine Program started in Barbados? Was it 1979, 1980, 1987, 1989, or 1990? All right. Answer, 1990. In Barbados, the DM Emergency Medicine Program was started by Dr. Raina Nedu, Professor Lenworth Jacobs, and Professor Sir Errol Waldron. And of course, continued by, how can we forget, our examiners, our advisors, our confidants, our help me at the airport, Dr. Harold Watson, and Dr. Reginald King. All right, next question. Who was the first EM-trained senior medical officer in Jamaica? So who was the first SMO to be emergency medicine trained? As we know, usually it's a surgeon. However, we broke that ceiling. The first emergency medicine trained senior medical officer in Jamaica. Is it A, Dr. Jacqueline Bisesa Mackenzie? B, Dr. Nicole Dawkins Wright? C, Dr. Edwarda Horton? D, Dr. Janice Miller? Or E, Dr. Andrea Johnson? Who was the first emergency medicine trained senior medical officer in Jamaica? Come on, guys. The basket will be worth it. I've seen it. Let me give you a hint. She's a female, but that's not a big hint because there are like 4 females. That's not a big hint. All right, so the first emergency medicine trained senior medical officer in Jamaica was Dr. Nicole Dawkins Wright. She was actually the SMO of Senans Bay Hospital. And so if you had that, guys, you got the answer correct. All right, next question. When was the DM Emergency Medicine Program started in Trinidad and Tobago? Is it A, 1979, B, 1980, C, 2005, D, 1989, or E, 1990? Was it before Jamaica, after Jamaica, before Barbados, after Barbados? Were you listening to Professor Jean Williams Johnson keenly? Were you taking notes? I should have given you a hint to take notes. So do we have a winner? Our technical team is working feverishly to ensure that we have the correct person for that basket. All right. Answer C, 2005 by Dr. Ian Sammy. There he is, Dr. Ian Sammy. And he's now ably joined by Dr. Joanne Paul, who is now the external examiner for the DM Emergency Postgraduate Program. In 2017, Dr. Sammy had the help of Dr. Ramlakan, and then Dr. Ramnarayan joined in 2017, and now we have the, what did Professor William Johnson say, the exciting and excitable and young and vibrant Dr. Salim Varashia, all right, since 2022. All right. Who was the first emergency medicine trained chief medical officer in Jamaica? So who was the first emergency medicine trained CMO in Jamaica? Was it A, Dr. Jacqueline Bisesa Mackenzie, B, Dr. Nicole Dawkins Wright, C, Dr. Edward Horton, D, Dr. Janice Miller, E, Dr. Andrea Johnson? Who was the first emergency medicine trained CMO in Jamaica? Let's see if you guys were paying attention. Where are you? All right, so if you said A, Dr. Jacqueline Bisesa Mackenzie, you are correct. She was the first emergency medicine trained chief medical officer in Jamaica. She was appointed in 2018 and she currently serves in that post. Go, female power. Sorry, I had to add that. Which year was the emergency medicine nursing course introduced at the UWI, and how many students did they start with? Was it in 1979? They started with 6 nursing students. Was it in 1980? 5 nursing students. Was it in 2005? 4 nursing students. 1995, 7 nursing students. 1990, 3 nursing students. Who will type the right answer? We have 2 more questions after this. All right, quick fingers. We have lots of different answers. All right, so the answer is D. The emergency medicine course for nurses was introduced at the University of the West Indies in 1995, and there were 7 nurses that were enrolled. Dr. Hilda Ming was the first nursing educator instructor, and she's on your screen. One of service, you know, I had to put that in. Which year was the point of care area introduced at the Emergency Medicine Division at the University Hospital of the West Indies? Was it in 1979? A, B, 2015, C, 2005, D, 2018, or E, 1990? So which year did we have the ability to do point of care tests for patients in the Emergency Medicine Division, University Hospital of the West Indies? Any takers? All right. Moving on. The point of care area was introduced at the Emergency Medicine Division, University Hospital of the West Indies, Mona, Jamaica, in 2018. And those are the ladies. You see the phlebotomists, they're usually well attired in their pink scrubs, and they're here flanked by the emergency room technicians. But yes, it was 2018. And now onto the Maxi Distribution Limited question, courtesy of Miss Natalie Robinson, healthcare specialist. The question, so We're gonna tally, and the persons with the right answer, you're gonna get a basket separate, and there's another basket for, well, from the Massey Distribution Limited, soon to be called Acado Distribution Limited. If you can answer this question, identify the device, this device, used to support emergency medical treatment. It's on your screen. Identify the device that is being shown used to support emergency medical treatment. So you have a few seconds and then we're gonna move on. We're running a little bit behind. All right, guys, you're gonna win a whole basket for this device. No other takers? All right, we give one more person a chance. All right. I think we have a winner, guys. So it's the iStat point of care system from Abbott. What it does, it provides accurate lab results. You get test results in minutes, and it tests a wide variety of tests. It's easy to use, it's portable, simple, and you can get lactate tests done, hematology tests, so your complete blood count. It tests chemistry and electrolytes, cardiac markers, coagulation indices, blood gas, as well as endocrinology tests. All right, so enough of me. I want to say thank you to Massey Distributors for providing us with prizes so that you guys not only came and you were informed and entertained, but you won a little thing as well. So we will soon be announcing the winner of the basket for the most answers for the recognition of local, regional, and international contributors to emergency medicine, as well as a basket for answering what device that was from Massey Distributors, soon to be called Acado Distributors Limited. All right, guys, so it's time to introduce our second speaker. He has been waiting. And who better to do this than Dr. Simone French, right? Who is our current emergency medicine course director and who has partnered with him for many, many, many courses, including the sonography course. And I do recall going to Detroit for 1 month to do my research elective. And in hindsight, if I had that 1 month again, sir, I'd make you more proud. Can I tell you? I think that was an awesome opportunity that we got in conjunction with Professor Williams Johnson, who was head at the time, to sit down for a month and ensure that our research project was sorted and we understood about research and what are the requirements. So I'm just saying thank you. And if I could get that 1 month again, I would publish more papers, sir. All right, so over to you, Dr. French.
Okay, good afternoon, everyone. I do apologize. We have a malfunction in blind, which is causing the sun to blind me as I speak with you this afternoon. It is my pleasure to introduce my colleague, mentor, and friend, Professor Philip David Levy. His CV is extensive, and I will do my best to represent him well. I do hope I don't make any errors. He completed his emergency medicine residency at the Bellevue Hospital and in New York University Medical Centers in New York in 2002, and he holds a master's degree in public health from the University of Michigan in Ann Arbor, Michigan, which he obtained in 2006. Professor Levy joined the Detroit Medical Center as an attending emergency medicine physician and became the assistant residency director in the Department of Emergency Medicine at the Detroit Receiving Hospital, Wayne State University School of Medicine in 2002. He rose rapidly through the ranks at Wayne State University, becoming a clinical assistant professor and progressing to professor of emergency medicine with tenure quite quickly, switching from the clinical educator track to the research educator track. In 2022, he was promoted to Joint Professor of Physiology and Emergency Medicine, a combination I must confess I've never heard before, in the Department of Physiology at Wayne State University School of Medicine. He's also the Chief Medical Officer there, and he holds that post presently. Professor Levy has extensive experience in clinical medicine, emergency department administration, residency program administration, public health, and research, and has held many interesting positions such as Chief Innovation Officer. He has received many awards for excellence in emergency medicine and in cardiovascular medicine, and has over 100 peer-reviewed and non-peer-reviewed publications. He has also sat on grant review committees at the National Institute of Health and consulted for many industry players. Phil, as we affectionately call him, is engaging and energetic. I first met him when he came to Jamaica with a team in 2007 to conduct an emergency department ultrasound course. I recall watching him as he, buzzed about with his energetic style and wondering, does he sleep? He later assured me that he does. He and his team staged the first full ultrasound course at the University Hospital of the West Indies, and that course had participants from emergency medicine, from surgery, and from anesthesia. As we developed the emergency medicine program at Mona, we were really fortunate to deepen our relationship with Professor Levy, who has been an immense help to us in many ways. He has presented at local conferences on several occasions and has been the external examiner for our graduate exams in emergency medicine many times. He is a connector of people. He introduced us to Professor Deborah Dirks, our external examiner for the upcoming DM emergency medicine exams, which we are about to enter in short order. He has, as Dr. Edwards has alluded to, he has facilitated the development of research skills for Professor Williams Johnson, for Dr. Edwards, for myself, and several residents who have been fortunate enough to visit the Wayne State University Integrative Biosciences Center, the brainchild of Professor Levy, which is affectionately known as iBio, and to learn from him and his team. This multifaceted individual has a depth and range of knowledge and experience that certainly makes him an excellent choice to speak to us on Emergency Medicine Day as we open our week of activities under the theme Elevating Emergency Medicine. Please welcome him as he speaks to us today about the growth of emergency medicine.
Thank you, Dr. French. Thanks to Romaine Edwards. Obviously, Dr. Edwards are pulling this all together, and big thanks to Gene Williams Johnson for many, many years of friendship and hard work together, as well as Eric Williams and the rest of the group from the UE Mona campus and all the other campuses, which, as you said, I've been doing the external examiner role with you guys for a number of years, and I've had the good fortune to travel to every campus, and I've really enjoyed it. The work that I've done with UE has been one of my favorite parts of my career, and I'm really delighted that I can be involved in this day, and was so appreciative when Romaine asked me to come speak. As I was telling the other speakers before, my only regret is that I'm not down there in Jamaica for this now, but again, happy to be here with you guys. So we're going to jump in. There'll be a little bit of overlap, not much, between what Dr. Williams Johnson presented and some of what I'm going to talk about, but really more for just exemplary purposes. So hopefully you guys can see everything on my screen right here. And We're going to talk about the growth of emergency medicine, as is habit for pretty much any talk that I give or a lot of others. Disclosures, none of this stuff that I'm presenting here is affected by the disclosures that I'm presenting. But as Simone mentioned, I've been doing research for quite a long time. I personally have had over 130 funded grants from various different partners, which means that I've submitted over 250 grants with many, many different partners over years. And research is really my passion. And as we kind of walk through this talk, we'll see how that's evolved over time. But I'm just, again, delighted to be here with you guys and delighted to be presenting this. So I want to talk about where all this actually began. It actually began in Treasure Beach when my good friend and colleague, James Sadock, was visiting uh, um, some friends down there in a hotel, Jake's. Some of you may know it in Treasure Beach. And a young child was drowning in the water, and he jumped in and saved him and realized that they didn't have water safety training down there. So we started to set up a course in water safety training, which quickly grew to first responder work and ultimately to the point where we purchased an ambulance, a group of colleagues of my, including myself and James Sadock, Aaron Hextall, Peter Gordon, Bill Goldberg. These are individuals whose faces are shown in the screen here. We purchased an ambulance, as you can see on the right side of the screen there, from Japan, had it shipped over to Jamaica and created the Treasure Beach Emergency Response Unit. What you can see in this picture, aside from a lot of other things, are two people. Myself right here, looking a little bit younger than I do today, and my daughter Sydney, who was down there with me, just a couple of months old at the time. Sydney is now graduated and just finished college, and she's grown up to be a wonderful young lady. And just going through this talk really reminds me that you have a lot of family that you love and cherish over time. And my daughter obviously is the apple of my eye, as is my son. But I really feel like the folks from UE and the partnerships we've created has made this family. And so I've never looked at the work that I've done with UE as labor. It's really been a labor of love. So moving forward, the ambulance service got started. This is the inauguration of the ambulance service, a prayer ceremony there. As you could see, we trained a number of people to be local medics to run this service, and it ran out of Jake's for a number of years. I was down there about 2 years ago with my wife, Mona, and the ambulance is no longer working. They're no longer doing this activity, but it was a good endeavor while it lasted. And one of the first things we did was publish on this, the third Mediterranean Emergency Medicine Congress, which was in Nice, France. And in 2005, we presented the first data on this. And so it was about 2003 that we started doing this work. And we started talking about what's going on in Jamaica and what the layperson ambulance service did and saw, and how many cases they treated and what was going on with there. And that was in partnership not only with our organization, which was known at the time of the International Society for Emergency Care, but BREDS, which is part of the Treasure Beach Foundation, and my good friend Jason Henzel, who leads that, and is somebody known to a couple of you guys from visiting the UE emergency department when he himself contracted dengue and needed some assistance. And I was delighted to be able to help him. Funny, he would come to me to get in touch with Jamaican emergency physicians to get connected, but he received great care and still today is very thankful for what you guys have done for him. But what happened from here, when we were moving in this process, we said, we really can't be trying to run an ambulance service from the States. And in fact, it's probably better if we maybe tried to get some connectivity with local emergency physicians to see what was going on. And from that conversation, we got connected with Dr. Williams Johnson. James Sadock set up the meeting. And I first visited UE in about 2005. And that was right at the time of Hurricane Dennis and Emily. I forget which one we were on the tail ends of, but we drove from Treasure Beach to Kingston to come meet with Jean for the first time in the offices right above the Scotia unit in the Mona campus, and things were off to the races. And from there, we learned that, Jean wasn't so interested in running an ambulance service in Treasure Beach, nor were there resources to be able to support that. But the emergency medicine residency itself was in dire need of research mentorship and growth, and the number one need that was identified there. So we kind of abandoned planned in hopes that we would be able to partner around the ambulance itself, which is probably for the better, and really started to dig in deep as to what we could do to foster research mentorship. And if I didn't say it in the beginning, I apologize, but I'm going to walk through a little of the history so you kind of know why the heck I'm up here talking to you guys, and then get into a little bit of deeper stuff around the growth of emergency medicine, understanding that we are at a crossroads as a specialty, and we're facing a lot of headwinds and a lot of challenges right now that will shape what the future looks like. And you guys are right in the throes of it. So, while research was the number one thing, I also thought that emergencies only taking place on Saturdays and Sundays, might be something else that we'd want to consider. But this is an older sign. I know that's obviously not the state of what's going on today, but I always like to put this one in talks because I think it's an interesting one to bring back some historical memory. So the next steps, I secured some funding, got grants from internally at Wayne State, and we were able to develop the research rotation that Romaine just mentioned. We set it up so that residents could come and spend 1 month in Detroit, working directly with me, where we would walk through the beginnings of how to develop a research question, to develop research projects, to launch research projects, to complete research projects, and take them forth to fruition. And we had 11 residents that came to work with us over the period of 2006 to 2010. As you could see, Romaine was in my first class right there with some other amazing people. And then we had a follow-up class thereafter. And I still remember all the projects that everybody who came through worked on. And I feel really proud of what was done. 2 SAM abstracts came out of this and 1 publication, which, Romaine, don't be so hard on yourself. You did pull through with the severe sepsis and emergency department paper at UE. And we were all quite proud of you for getting that done. And from there, we continued to grow things. I got some additional funding, and instead of having residents come up for a month at a time, we set up a research symposium in 2010. I came down with my colleague, Scott Compton, and another individual, and we had 5 residents in next class, to come up and spent almost a week with us working out of Strawberry Hill, which was quite a nice thing. This is an actual picture from the time, sitting up in the Blue Mountains and enjoying the fresh Blue Mountain coffee and discussing research in one of their conference rooms. It was a really fantastic experience. And aside from the drive, which I know is no fun for anybody, both up or down from that location, it was a really good way for us to sort of flip the script a little bit and say, we can bring resources down to you guys and we can work with you. As was mentioned along the way, we had conducted an ultrasound course where we had, I think, almost 60 people participate. And we had brought down an ultrasound machine, which I hope is still not in the emergency department anywhere being used on humans. But it was an ultrasound machine where, in fact, one of the first things we did besides teaching was diagnose an aortic dissection. And I forget exactly who picked up on that. I have a feeling Romaine was somehow involved in that. But I remember that there was astonishment that the emergency department could actually detect an aortic dissection with an ultrasound machine that was relatively, archaic, a little beat up over time, but still highly functional. And I think everybody walked away from that training with a great experience. And then probably one of the biggest culminations of activity that occurred was, as was mentioned, Dr. Williams Johnson was awarded a Fulbright scholarship where she spent 3 months with us in the city of Detroit. We rented a nice little apartment around the corner from Detroit Receiving Hospital in Wayne State where I work. And Gene, I don't know if you remember this, but when we walked into that apartment, the garbage disposal hadn't been cleaned out in a while, and it gave off an awful odor. And I remember dropping a lemon down there, and that cleaned up the problem, and I was quite happy for that. But Jean spent 3 months with us in Detroit, a lot of running around. She had some family in the community too, which was nice. But every morning, Jean and I would get together and talk research, and we studied specifically hypertension because we started to become aware that there were a lot of parallels between Detroit and Jamaica, especially Kingston, similar demographic, albeit culturally different, and similar rates of hypertension. So we started to publish on that. Again, Jean got the Fulbright Scholarship. It was one of the awards at the time for scholars and professionals from the Caribbean and Central America. We started to work with others in the department, including Dr. Gossa Williams, one of the statisticians, who I don't know if she's still working with you guys, but was instrumental in helping us pull some stuff together. And we talked about compliance and hypertension, and then started publishing some work looking at hypertension beliefs and explanatory models, comparing Detroit to Jamaica and then Tanzania. One of my mentees, John Pirocal, who had spent some time in Jamaica, had spent some time in Tanzania, had pulled together data for us in this. And in fact, John's now at Duke, and I'm going to see him next week when I go down there to give grand rounds for their Health Equity Day. So it's kind of funny the way the world comes full circle. Along the way, I also did something that I've wanted to do pretty much my entire adult life, which was hike up Blue Mountain. And here you can see going through Portland Gap. And I was really excited to get to the top of Blue Mountain, but realized there's not a heck of a lot up there once you do get up to the top. But what was kind of interesting is Jean set me up with her personal trainer to be my guide for the day. And we got dropped off in one of the towns nearby, not directly where you enter the park for Blue Mountain, about a mile and a half away. And we walked up along the street to what I thought was the turnoff to Blue Mountain. He said, no, 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 we go this way. And we went and the entire different wrong way down this whole thing down to a river where we saw somebody doing some maintenance work. He's like, no, no, you got to go all the way back up and then you got to turn over here. So we get all the way back up. And then Gene, your buddy, sat down and decided to have a red stripe while he sent me up the hill by myself. So I went up to summit the mountain by myself, which was wonderful. And then I came back down begging and hoping in my mind, because at that point it was about 25 miles of walking, that he would be there with a car to take us out. And I got down there and he's relaxed. And I said, where's the car? He goes, oh, no, no, you got to do the whole thing. You got to get all the way back to where we started. I said, oh, my God, what's going on here? Anyway, we went out for Chinese food that night. I don't know if you remember, Gene, and my legs were so sore I could barely walk the next day. But anyway, I enjoyed that experience immensely and was very proud to have been one of the few people I know who've ever been to the top of Blue Mountain. So they started to develop a directionality too, where not only did we have residents come up to Detroit, we started sending some residents down to Jamaica. One of the first residents to go down there was Mark Dalton, and Mark was affectionately known as Honey Bear, as his nickname. He came down and in our spirit of bidirectionality, spent a month in the emergency department and came back and gave a talk to all of us in Detroit about what happened and decided to throw in his try at Rastafarian in explaining the experience. I'm not going to insult you guys or make a fool of myself by trying to read all of this right now, although I will say we had a good time in the past when Simone and others would give me not such great words to say in front of other people when they would walk in the room and then have a good laugh at me regurgitating these expressions. But as you can see here, this is a pretty humorous take on working down in the emergency department, but doing things like morning report so that people can get that sense of how you discuss cases and work through them, follow up rounds lectures and all that type of stuff. So it was a great experience. As it says there, we run things not run we. So, I guess I'll jump in a little bit into that. But now, what has come of all of this work, simply from trying to figure out if we could work together around an ambulance service, we've developed an MOU, or a Memorandum of Understanding. My colleague, Arun Kumar, has taken over this work in terms of a relationship and back and forth work. But we've developed an MOU between Wayne State and University of West Indies, which was first established in 2017. And I know we just re-upped this recently, which allows for areas of collaboration, student exchange, collaborative research, co-sponsorship on projects and conferences, and development of academic initiatives. And I think, I'm particularly proud of getting to this point, right? Something that, again, just started as a conversation, led to something really deep, both personally through these amazing relationships that we've developed, but also professionally and academically between our respective institutions. But let's get back into the sort of bigger picture of the growth of emergency medicine. So again, that's why I'm here talking to you guys. That's why I'll always have Jamaica and University of West Indies in my heart. But international emergency medicine is a relatively new concept, as was stated, right? So this article talks about the development of emergency medicine worldwide. It was published in 1999, so not the newest piece of literature, but formative for understanding timeframes. And it shows here emergency medicine in the the primary countries where it initially started. And the first, even though the official specialty date year, as Romain correctly stated, was 1979, the United States, shortly followed by Canada in 1980, Australia in 1983, and then 8 years later, the Philippines, followed by another host of other countries. We started this in the U.S. in 1968 with the first National Society around Emergency Medicine developed residency training before we were a approved specialty. created specialty journals and boards and that type of stuff. And ultimately, that's how we solidified ourselves as a specialty, amongst many others in the United States. And it was very difficult, to get through this process. The emergency medicine was rejected numerous times. A lot of people would disparage the concept of emergency medicine as you're just a location, you're not a specialty. And a lot of people involved in sort of the hierarchy of the House of Medicine, would conceptualize that if you're not really an organ specific specialist, then you're not really a specialist at all. You don't deserve to be a specialty. But as Dr. Williams Johnson, very nicely articulated, our role is to be prepared for whatever comes in the door before us. And we don't always know what that is, which means that you can't have all these preconceived notions about what you're going to deal with, or better stated, what you're not willing to deal with, because we don't have the option to not deal with anything, right? We have to take what comes our way and do our best moving forward. And I think that's the ethos of everybody who becomes an emergency physician, right? You guys have probably heard this. I know I've heard it many, many times, that there's a persona of emergency medicine. And oftentimes it's equated with adventurous, free spirit, cowboy, those types of terms. But I think more importantly, it's none of those things. It's actually people who really want to have as broad a knowledge base as possible, with depth that, you can go as deep as you want through further academic growth and research and those types of things. But it's having that breadth of knowledge that allows you to handle whatever comes your way. So, I just put this up there to give some background. But as Romain also said, right, this isn't this isn't something that's been around for 100 years. This is still relatively fresh. And even the concept of Emergency Medicine Week, right, speaks to the need for us to remind others that we are something different and something unique. You don't see Internal Medicine Week or Cardiology Week or those types of things, right? And it's important for us as specialists and as emergency physicians to, stay true to our roots and not shy away. But since then, since that publication in 1999, emergency medicine has continued to grow. There's now 68 or 70 or so countries where EM is a recognized specialty, maybe a little bit less than that, but an equally growing number of places where emergency medicine training programs are. And those two things really go hand in hand, because it's that respect in medicine that's so important, to know that you have a unique knowledge base and that your information is contributory to the betterment of the care of the individuals that are before you. If you abdicate that responsibility by calling the consultant immediately, or not even getting a chance to see the patient before somebody else who supposedly has higher knowledge bases, comes down to tell you what's going on, that's going to be a difficult situation. I had the good fortune of, amongst the publications, Simone, sorry to say, you got the publication number wrong. It's closer to 300, but we're not talking about that right now. But one of the publications that I'm most proud of is being the vice chair and second author for the 2021 American Heart Association and American College of Cardiology chest pain guidelines. So basically, through work that I've done with the ACC over years and the AHA, I got put in a position to help lead that document and basically help define the way we manage and think about chest pain care in this country. Yet, as an attending physician in the emergency department, I would still get cardiology fellows and internal medicine residents who'd want to come down and tell me, how this should go. And I would say, well, why don't you look at the guidelines? And if you want, I'm the second guy in the paper there. So happy to clue you in on what it's saying. But when we look at emergency medicine around the world, there's this ambassador program that ACEP runs with different countries. And I think Judy Tintinelli was the first and for a while, one of the long-serving ambassadors for Jamaica. And then my friend James Sadock took it over, and I'm not sure who's in that role right now. I have always thought that I would like to do that, but I never wanted to fill out the paperwork, to be quite honest with you. So I apologize for, not taking on the mantle there. But ACEP runs sort of annual reports from these ambassadors, where they bring in different information. And reading through this report, it was a survey that described emergency medicine and what people are encountering in different countries through the lens or the eye of the ambassador. Most important and most telling thing that I came across were what were the threats to emergency medicine, right? And we heard a little bit of this from Jean and Romaine as well. But thinking about what are threats, most of the countries, or the majority of countries that responded, 38%, 20 out of 52, talked about limited economic resources in the system, and then burnout, partly from the working conditions that people experience. Obviously, there's things like low salaries, mismanagement, and you can see a whole list of other things that come up right here. But these are all really important things that if we're going to continue to move and grow emergency medicine beyond what's happened in the last 2 decades or so, these things are going to have to be combated. And I know that we were talking about greener pastures that was mentioned, but it's really important to know that the brain drain is real, right? It's not just physicians, it's nurses, it's mid-level specialists, whatever you can think of, right? And it's hard if you're going to put all your time, effort, and investment, if you will, into training people and then seeing them leave. It can be a little bit I don't know if demoralizing is the right word, but it's just it would be nice if people didn't have to leave where they trained or leave the country, where they got their education to go find greener pastures elsewhere. But hey, that is life, and there's not much we can do about that. And I think things like this, lack of leadership within emergency medicine, fortunately, as was highlighted again by Jean, but especially by Romaine, there's a lot of really outstanding leadership that's been here at UWI that's allowed Jamaica, Barbados, Trinidad, Tobago, Bahamas to really be leaders in an entire region, the entire Caribbean region, and extending further South America, even over into Asia, where I know that you guys have a lot of you guys have gone before for conferences and presented information and research. So, I think that one thing that you guys should be really proud of is that not only do you have a lot of extensive and outstanding leadership, you've had at least, in certain institutions, institutional commitment to emergency medicine as a concept. And, you practice within a relatively organized and regimented healthcare system in general that for the most part, values the role and contribution of emergency medicine. I will say, having been an external examiner numerous times, the British sort of training system that you guys work under, very distinct and different from what we do in the United States. I think there is a lot of truth and value in the way it's approached, although all the other examiners have heard me say nobody in 2025 really is percussing liver borders anymore. We can do that with an ultrasound and get a study to look further into that. But that's aside, I do think that the distinction between sort of the different specialties, different training grounds for emergency medicine is really important and does help to sort of foster that collegiality within the own institution itself, right? If you guys were deviating from what everybody else in the institution was doing for training, first, you probably wouldn't get, your residency certificates at the end. But I think it's important to, kind of be a team player with the rest of the institution. But I thought that this was interesting to kind of show that despite growth, there are challenges ahead. And the rest of the time here, I'm going to talk a little bit about not just the growth, but actually what might be inhibiting or things that we have to think about going forward. So we talked about boarding and crowding a little bit, and this is a problem everywhere, and it's only gotten worse since the pandemic. So truth be told here, I mentioned this to Romaine. I haven't worked in the emergency department in a couple of years. You'll see towards the end of the slides as to why that is. But the last time I did work was 2023 over Christmas. And that's when, we were still at the peak points of the pandemic. I think that was the Delta variant at that time, maybe the Epsilon, I can't recall. But, I remember being in emergency departments, for 4 days straight, working over the Christmas break. And it's usually a little bit of a lull period there, save the, family member who comes home and is shocked to see their parent that they haven't seen in 3 months in a debilitated state. And so they rush them right to the emergency department. But, it's really more chronic than acute problems. But, over that period of time, I saw on average 5 to 7 people a day. Not a lot. That's in an emergency department that was seeing 90,000 people a year prior to the pandemic. That dropped to about 42,000 during the pandemic. But the place was filled with boarders. And I spent more time changing masks on people and handing out food than I did actually being a doctor. And, while that's me and my perspective on where I can contribute to healthcare, I think this is a very real problem. There's a lot of effort to try to quantify, if you will, the deleterious or negative impact of boarding on emergency patients, and it is very real. And in 2021, a number of luminaries in emergency medicine published something in New England Journal of Medicine Catalyst. That's not exactly a full NEJM publication, but they talked about the impact on boarding for admitted patients in the emergency department and as a sort of function of the hospital volume. And what you see here, breaking down admitted patients and the proportion of below 85%, 85 to 90%, and above 90% in the hospital census, and how that affects the trickle down for boarders in the emergency department and everybody, back out to the waiting area and then into the community and what have you. And I think the biggest thing I take away from this is that, yes, we're included as a specialty and we're together with the rest of the world of medicine, but in a hospital perspective, we're often seen as something where there's infinite capacity to expand, right? But we're more like a balloon than something that's got infinite capacity. You keep blowing it up, it's going to pop eventually. And I think one of the keys towards addressing this boarding problem is starting to think of emergency departments, not the specialty and not the physicians or nurses or anybody else in the, who's working seeing patients, but the actual physical location as something that's part of the bigger picture. So anytime a patient's not discharged on the floor for a couple of hours because they're either waiting for a test or the consultant couldn't get to see them before they were time to go, or somebody wanted something to happen, that has a trickle-down effect where somebody's getting stuck in the emergency department waiting for that bed. And we have to start to think more holistically if we're going to make a difference. So I would say for us to continue to grow as a specialty, this is an important problem to overcome. Not only is it a problem for the patients that we care for, it's a problem for interest and training in our specialty. So Detroit Receiving Hospital is one of the oldest programs, Wayne State. Detroit itself has a lot of history with Henry Ford Health as well, creating programs in the 80s and early 90s when it was just getting going in our country. And what we've come to kind of understand, right, is that we train a lot of emergency physicians. In fact, at Wayne State University forever, emergency medicine had been number one or, in the top two or three residency training programs for graduates of medical school. Upwards of 40 to 60 people a year were going to emergency medicine. Last year, it was 11. And it keeps on declining because our residents, or excuse me, our medical students who rotate through the emergency department look around and say, what am I going to do this for? Why would I be involved in this type of care where I'm not able to do full management of my patients who are boarded, yet I'm still held to the outcomes, and doing things like chronic inpatient components because there's nobody else to do the job. So I think it's really important. And last but not least, right, we have to kill this concept that the emergency department is something that can be exploited because people are there. So rather than open up a new unit upstairs, it's easier to just put more beds in the hallway because you have people who are going to get paid to be in the ER anyway. And so really important for us to think about this as we want to grow emergency medicine. We got to really understand the role of the emergency department as a functional unit compared to the rest of the hospital. Likewise, ED violence. I think this is a really important thing that we've often tolerated in emergency medicine, right? Patients are under stress. There's a lot of mental health cases. There's a lot of substance use disorders going on, a lot of alcoholism, right? And so people can come to the emergency department and it's just part of the job that, you're going to have some loud interaction and God forbid some, physical altercation, right, with a patient. But it's starting to become more and more recognized that this just isn't okay. And it's not fine for somebody to yell at a doctor. It's not fine for somebody to be rude to a nurse. And it's not fine for anybody who's a patient to put their hands on a caregiver who's just trying to do the right thing. So ACEP has really tried to run with this in the United States as well. And in a survey just published in 2023, looked at colleagues who've been threatened or attacked, as you can see in these circles, and 91% of people say they have. I remember when I was a resident at Bellevue Hospital, I was standing at the nurses station and a psych patient came up and jumped on my back literally, and I had a scrub top on, and grabbed like a handful of my chest hair, and I was like, "Whoa, this is awful," right? And you kind of wonder why you're doing what you're doing sometimes, right? But it seems to be getting worse. And as you can see here, the prevalence of violence in 2023 worse last year, about the same, but not less, right? And mental health issues leading to this. Why do you say it's worse? Challenges related to boarding, angry patients, some combination of it all, right? Employers not really supporting people. And then that leads to things like the quest, if you will, or the desire to say, how do we fix this? Well, you can try it within the facility itself, but we really need to protect our workforce, right, with legislation to make it illegal and a crime, right, to assault a healthcare professional. And these are the things that we're trying to push in a lot of different ways in the United States. And again, something that I think is important for our continued growth as a specialty. We have to acknowledge that, again, it's not okay. Physical violence, mental abuse, all those types of things, verbal abuse are not part of the job. They shouldn't be there. And I thought this was interesting, a recent publication looking at just one emergency department where they reported that a healthcare worker experiences workplace violence once every 3.5 shifts or so. And I thought these were interesting when they typed it out into just type one, yelling and shouting, type two, threats of physical violence, death threats, whatever, and then type three, actual physical violence, right? What does that look like? And then comments, sexist comments, as you can read here, where, horrible things being said to somebody who's there to help them, racist comments as well. And I think we've all had that encounter where somebody's really drunk and they say some horrible things, and when they sober up, they're really embarrassed, right? But that's what I've seen lately. That's more of the exception than the norm. And I think people have just been desensitized towards their worst self, especially in the United States with our current leadership and all the baggage, if you will, that comes with that. The other thing that's come up too that's been a threat, and some of you guys may have seen this, there was a published report a couple of years ago from the AHRQ that talked about diagnostic errors in the emergency department, and it was a systematic review that was conducted. And basically, the systematic review looked at multiple different publications and came up with the estimation that the diagnostic error rate in emergency medicine is about 5.7%. That means 1 out of every 18 patients who are encountered in the emergency department is going to be a victim, if you will, or suffer from diagnostic errors, which leads to, if you break it down, compared to about 130 million annual visits in the emergency department, almost 7.4 million diagnostic errors occurring in the emergency department with a 2% adverse event rate. Again, this is all projected data. It's all conjectured, based on extrapolation. But that's 2.6 million adverse events with serious harm in about 14.5%, which means that almost 380,000 people are suffering serious harm because of diagnostic errors in the emergency department. What contributes to these? 6 of the top causes of this are cognitive on the part of emergency physicians, right? Not ordering appropriately or failure to order certain diagnostic tests, lack of adequate assessment and premature discharge, narrow diagnostic focus or anchoring or even premature closure, right? Where you don't look at a broad enough differential because you're so convinced that it is what it is, even though it might not be, right? Failure to appreciate and reconcile evolution or dynamic changing signs, symptoms, or test results, getting the appropriate consults and referrals, missing interpretation of diagnostic tests. And this is an important thing. But what was perhaps most important is this undermined our credibility in the world of medicine. And so some of this comes because a lot of times the evidence that we work off of in emergency departments it's incomplete, and it's not the best set of evidence, right? And why is that? Because it's hard to do randomized controlled trials on a lot of different things that we see, because we often see symptoms with a complete lack of differentiation across those symptoms. And our goal is often not to come to a diagnosis, but to come to the conclusion that that patient is safe or not safe to be discharged, and an expectation that someone else is going to pick up where we left off. But what comes from this, and this is published a couple of years ago now, but still, again, the database hasn't been that strong. This is looking at the guidelines or the clinical policy statements published by ACEP over the years, starting in 1990, moving forward at this point to 2015. There have been more since then, and just showing the breakdowns of categories on the right side. What was in the past is an open circle. What's current is a darker circle. And then looking at the level of evidence. So level of evidence A is the highest quality of evidence. Level of evidence C is expert opinion. Class 1 are good randomized controlled trials. Class 2 and 3 are much lesser quality trials. And what you could see across the board here is that very few of our clinical policies from, at least in America, the premier emergency medicine organization, are based on high quality evidence, and a lot of it is based on expert opinion and lower quality of evidence. And so that makes it harder sometimes for us to know what the right answer is because we don't have the evidence to guide what we're doing. Although, as you heard from Jean, right, your participation in CRASH 2 really helped us understand that tranexamic acid has an important role to play in certain patients, although for whatever reason that I'll never understand, it hasn't really been taken up in clinical practice on a routine basis. But anyway, this is one of the things that may be behind the fact that it's hard for us to always come up with the right information because we don't have the right basis for that. But it could also be that we just, they didn't do a good job on the study, right? And so ACEP really came to bat and defended emergency medicine with this, talking about the devil being in the details. And the way they looked at this, they didn't take just data from the United States. They took data from all over the world. And they talked about a large Spanish study that turns out most of the data came from the Canary Islands, which is not representative of any main emergency department, at least in the United States, and probably not even what you guys are used to, in the University of West Indies and across the area. And I put a quote up here from Lewis Nelson, who's a good friend of mine and colleague from Bellevue Hospital, from the Poison Control Center at New York when I trained there, but now chair at the Department of Emergency Medicine at Rutgers. And, that the article is just fully inadequate in every way and generalizing from a few papers across different eras, right? Because some of these studies were published 15 years ago and different geographics. It's very hard to make a summative judgment or determination around the quality of care and the likelihood of making diagnostic errors in the emergency department. But one thing to say is that, could look bad, or you could think 5%, 5.7% is a bad number. That means 95% are doing pretty well. And so if you have 130 million visits and you're getting 95% correct, I think, you're doing okay, especially if those diagnostic errors aren't always going to lead to a truly untoward outcome. They are sometimes, right? And that's something that we need to think about. But it's important not just to take these sensational headlines and sort of condemn the entire specialty around that. And then the other thing that's going on is, you guys may have seen this as well, projections for the workforce in emergency medicine saying that by 2030, we're going to have an excess of emergency physicians, that we're training too many ER docs in the United States. And so what does that mean? That means that we're not going to have as much capacity or room for others outside the United States to get trained, right? But this was at a different time. This was when emergency medicine was still garnering a huge amount of trainees interested in the specialty. For the first time ever 2 years ago, emergency medicine barely filled in the United States, right? And typically every year for the match in the United States, there may have been 5, 8 open spots. 2 years ago, about 35% of the slots were open in emergency medicine in America. And that tells us that, maybe we're not having this looming projection of shortage for emergency physicians, right? But it's definitely a difficult thing to say that we need more and more of people to come into the specialty if there's not a place for them to work. But why might that be? Well, one of the things that's really started to happen is, as a threat to emergency physicians, because there's been a for-profit motive in the United States, at least, that stepped into emergency medicine, where you have venture capital groups buying specialty practice groups. They look at it and say, if I can do the same job with someone who's cheaper, why don't I? So they started to pull in nurse practitioners and physician's assistants to run some of these emergency department components, at least urgent cares, and in some places, the main emergency department itself. And when they did this survey or this analysis in 2021, only 59% of all emergency physicians were EM trained residency physicians, right? The other groups, you had internal medicine and others, but you started to see nurse practitioners and physician assistants representing almost a quarter of the workforce in emergency medicine. And that's become a big problem. ACEP has jumped on this. CNN, has published things like this just a couple of years ago. Why you aren't guaranteed to see a doctor when you go to the ER, because it's cheaper to have a nurse practitioner or a physician assistant do that same job. And that type of thing can undermine further growth and development of our specialty. If somebody who's lesser trained can do the same job, then what are we, right? I've always felt this way about moonlighting, and I don't know. Again, I probably should know this, but I don't. If that's allowable, in your training areas. But for a long time in the United States, as a senior resident, when I was a fourth-year resident at Bellevue Hospital, I could go work in emergency departments and get a moonlighting rate, just as if I was a board-certified attending physician. If a resident can step in and get the same thing that a board-certified physician is, well, what do we need to be board-certified for, and what's the training? So I think, we got to be careful not to shoot ourselves in the foot along the way. And so ACEP has really taken the mantle about physician-led team care and really putting physicians at the center. There's a bill in Michigan that's being reviewed now that is going to allow nurse practitioners to operate in emergency departments completely independent of a physician. Right now, physician assistants, one thing, but nurse practitioners have to work under the license or at least adjacent licensure to an emergency to a regular physician. They're trying to make them more independent practitioners, which is obviously a concern to organizations like ACEP. And then finally, kind of wrapping up here in this history and expansion into the future, recent publication in the Western Journal of Emergency Medicine that kind of walk through the very early days of what's going on. And Romain, excellent job right there, talking about Luray's flying ambulances in 1812, moving all the way forward through many different trials and tribulations, and then that projected oversupply in 2030 of emergency medicine. Perhaps the most important thing I took away from this is that not only are we emergency physicians who do emergency care, we're also entrepreneurial and open-minded innovators, and that we can do many, many other things. There's a number of specialties, subspecialties within emergency medicine that you can get certified for, right? Some of them have boards that you can go into, like addiction medicine, brain injury medicine, what have you, ultrasound, right? We know that there are a number of unaccredited subspecialties as well that people can do, neurovascular, stroke, what have you. And then there are new frontiers, correctional medicine, hospitalist medicine, things where you can cross over and do multiple different components. The last thing I want to highlight, though, is this idea of health policy and public health. That's where my career has evolved to. It started before the pandemic, focusing on emergency departments as places to try to begin the effort to decrease the impact of high blood pressure on populations at large, and truly trying to reduce cardiovascular disease risk and deaths amongst communities by taking the blood pressure we measure in the ER and doing something with it other than nothing, right? Which is what we do most of the time, unless the patient's hypotensive or they have a hypertensive emergency, which is kind of rare, although always feared. Where I started going with things was saying, can't we take these emergency departments and then understand, the blood pressures from the emergency departments, understand what that represents for the public health of the populations we serve, and do something with it. When the COVID pandemic hit, I started taking this on the road because we saw declining emergency department visits, and I developed a mobile health outreach program to initially bring COVID testing and vaccinations to communities, but then evolved to a vision of portable population health, where I developed a fleet of mobile units and really started to reimagine how we can make hypertension care a community-based thing, taking a data infrastructure called Phoenix that we developed, and envisioning new futures of care like this, where we take data on high blood pressure at geospatial levels, right? Neighborhood by neighborhood levels, look at factors like social vulnerability that play into it, and then deploy resources, in this case, mobile units, into communities to measure blood pressures and treat people so that we can do more public/population health, from a community setting. And this came from my sort of background or idea as an emergency physician, which is, what's the fundamental problem here? Let me fix that fundamental problem, rather than just accepting the problem and figuring out how I work within it. So wrapping up right there, that's my email. If you guys have any questions, I'm happy to take any of those by email. I know we're over time right here, but I blame Romain for that, not me. I think we'll have Romain, if you want, a couple questions here if there's time. But otherwise, just wanted to wrap up by saying this has been an amazing journey with my colleagues and friends through the University of West Indies. And once again, I'm just delighted to be part of this experience. And thank you so much for inviting me.
Wow, thank you very much, Professor Philip Levy. I thoroughly enjoyed that talk. And yes, thank you for throwing me under the bus about the time. I can't believe we had such a great partnership with Wayne State University, and through you, we've accomplished quite a bit. What I wanted to ask you, right, while my able technical team scans the chat, is Okay, so being honest, up until I remember visiting one of our neighboring hospitals in 2012, the Jamaica Emergency Medicine Association had part of its activity where we would visit another emergency department. And I remember looking at them and I was like, you guys literally have people boarding in your resuscitation cubicle? And I actually found it so strange at the time because we had actually enjoyed when patients come, we assess, we resuscitate, we stabilize, we investigate, we diagnose, and they were disposed of. So they were either admitted to the ward or they would be transferred to Kingston Public Hospital. Fast forward to about 5 or 6 years later, when we started to have a lot of admitted patients, especially internal medicine patients, stuck in the A&E department, primarily because Kingston Public Hospital said, listen, we're not going to take your transfers of admitted patients anymore. You have to deal with it. And so what has happened, and then fast forward COVID and post-COVID, is that we start to look like our neighbors. In fact, sometimes we have started to look worse, where we have between 35 and 70 boarded internal medicine patients in the emergency department. Luckily for us, we have the emergency holding area, formerly known as the field hospital, which was a temporary area for disaster. And so, you know, we got a chance to house some persons there, right? Temporarily until they get to the ward. But we have a constant number of internal medicine patients in the department between 35 and 70 on a daily basis. And to be honest, yes, I know that it is, I would say, global challenge, but I think there are ways in which we can manage that. Hear me out. Our leaders will look to your hospitals and say, yes, but it's happening everywhere. The issue I have with that is an overcrowded ED in the US is a little different from an overcrowded ED in Jamaica, because the overcrowded ED in Jamaica does not have the number of persons doing their vitals continuously and monitoring them in the hallways as opposed to in the US. So for example, yes, the patients are waiting in the triage area, but they have their vitals continuously being monitored. Yes, they're waiting to go on the ward, but the ratio of doctors and nurses to patients is much smaller than ours. So I think our leaders basically have looked to what you guys have been struggling with and have said to us, it's a worldwide problem. What is your problem? And I don't see solutions being offered. I have heard of persons saying, yes, you know, if you build more wards, what you will have is more people. But what do you think is a real approach to that kind of situation? Because I think overcrowding, it's not helping us as a specialty, because persons are actually being turned off by having to come to A&E and not have to manage emergencies, but to manage admitted patients. So, you know, I realize that what you have done by taking, you know, hypertension on the road, basically, that if you can manage that, you will offset some of the patients coming to the emergency department as emergencies, right? So I guess bolstering primary care, but majority of the people are already there. We have the emergencies and we have the admitted patients. You know, what do you think, apart from, I don't know, is it that the emergency department should be able to say, all right, assess the situation and say, you know, we are full, we cannot manage anymore? Because I think persons seem to think that we can expand and expand and expand, right? And while the wards can say we're full.
Yeah. No, that was my point, talking about the balloon bursting, right? I think you're 100% right. They used to do a lot more emergency department closures or, telling EMS you're at capacity, you can't take any more ambulances, but all you end up doing then is just shifting it to somebody else like, KPH or whatever it might be. So I don't think the answer is anything in isolation where one emergency department looks to do what's best for them. And I don't think you're implying that in any way, Romaine. One emergency department looks to do what's best for their circumstances to the detriment potentially of the patients that would have come in, because they'll go somewhere else where it's also crowded in the other facilities that might not have, the same level of resources at that location. But I think it gets back to that main point right here, which is that whoever is behind the decision making here really has to be holistic and understand that when, well, maybe phrase it this way, you got to shift your mindset from the patients are lucky enough to be here to patients are customers, and we really need to make this experience as good as possible so that people will want to not only come here when they have to come here, they'll want to come here when they have choices where they could go, right? And that's what I mean. You're in a car accident, you're on the backboard looking up with a neck brace, right? You go where they take you, right? But if you're going to go for outpatient procedures, you're going to follow up in clinics and those types of things, you have a choice into what you're doing. And at the end of the day, the unfortunate thing with all of healthcare is that it's a business, right? And that if these facilities aren't making revenue on the activities that they're doing, they're going to try to figure out ways to cut support services or pull back on what they offer. And I don't think anybody wants to pull back on what they offer. So what they end up doing is scaling back on things that perceive not to affect their bottom line. And that's what I, meant also by that exploitation of the emergency department, where it's easier to board 50 people in the ER than to open two more wards because the ER doesn't have a choice, so to say, right? Because those patients are there. And yes, you could say, okay, wait for the internal medicine team to come down and round on the patient. But every time you walk by that individual who's looking at you, wondering, why aren't you caring for me like you're caring for everybody else? It's a very, very tough thing on you as a person, as a physician, especially. So I don't have a real good answer for you, Romaine. In fact, I think nobody really does at this point, other than to say that's kind of the evolution of where we're at. But I think we're all fed up with the circumstance, and probably the only thing that's going to make a difference is, and I hate to say it, is a high profile tragedy that's a consequence of this, right? Somebody who ends up having an adverse outcome, who's in a position to make that noticed, or their family is, or whatever, however you want to conceptualize it, because people only listen, when it has implications both from a financial and a medical legal perspective. Again, I hate to frame it that way, but there's just not that concept of we're all in this together to serve a group or community as a bunch of colleagues and collaborators. We're these disparate components of a very poorly oiled machine that doesn't work quite well, but it works well enough that we're getting by. I know that's probably an unsatisfactory answer, and I wish I had a better one for you. But this is the the big struggle in our specialty right now.
Okay, thank you for that, Prof. Not seeing any other questions in the chat. I think both speakers, you guys were very clear. I'll put your email address so that if anybody has any further questions, they could reach out to you or Professor Williams Johnson. Just to say quickly that thank you again, Prof, for an inspiring talk. Really enjoyed it. You managed to, grab and keep our attention, can I tell you? I was actually very impressed by the story. I think you told us, but how it all started when you saved that kid, and what has happened since then. You should write a paper. All right. So just to say that with regards to our questions, we have a winner. So it was very close between Dr. Kim Villarreal and Dr. Joan Bradford. However, Dr. Kim Villarreal answered the questions faster. And so, Dr. Kim Villarreal, you have a basket courtesy of Massey Distributors, soon to be called Acado Distributors Limited. to pick up at the Emergency Medicine Division. So you're the winner of the trivia. Also, the winner of the Massey question is none other than our recent graduate, Dr. Monique Guy. So just want to say, Dr. Guy, you also have a basket here from Massey Distributors. Congratulations. All right. I know that we had an enjoyable afternoon. I did. And it was entertaining, informative, and some of you have won prizes. Please be reminded that we need your participation for our week of activities coming up, and we would look forward to having you guys participate, especially at 1, our church service, 2, the expo on the Monday, 3, the sexual assault webinar on the Tuesday afternoon, 2 to 4. The Wednesday morning, the quiz, I don't think that will be streamed, it will be in-house. We'll have the Lime Wednesday evening, the Thursday netball and football competition. Come out and cheer for your team, hopefully Team C. The Friday at Alhambra Inn, I'm hoping that Dr. Hudson can get us to stream that forum. It should, be exciting. She has a nice panel lined up, along with Professor Williams Johnson, of course, entertainment. And we look forward to that. And on the Saturday, we have the road race / walkathon, and the banner is up live, and we will soon distribute how it is that you can participate. Okay? All right. So it just leaves me now to say thank you very much to all the persons who made this event possible. We look forward to you participating in our other 7 days activities. We want to thank the Bahamas for triggering this event. Thank you very much, Dr. Krista Wells, for your guidance. You were very open. You helped me out. You detailed what it was about, the challenges. And I think your boss, Dr. Liz, she was the one who actually gave me some ideas when we were sitting at dinner as well. Want to thank the Emergency Medicine Week Committee. It's made of consultants, residents, medical officers, nurses, ERTs, phlebotomists, and our hospital PRO. And of course, I pull on my friend, Miss Kadeen Webley, a lot, and her daughter, Kiera, for, because that's what she does for a living, organize events. I thank them for being strong links in this chain and ensuring that we celebrate emergency medicine on this our special day, and that we will continue to do so in our week's activities. Special thank you again to both guest speakers and the persons who introduced them. You did a good job. All the sponsors, thank you, Massey, soon to be called Acado Distributors, for your gifts today. Thank you to my technical team, Dr. Errol Williamson, Dr. Rhonda Hudson. I'm hoping I'm not forgetting anyone, the admin staff. Thank you very much. For those of you who bought into our vision of Emergency Medicine Week, we just want to say thank you, especially to our audience. You guys were attentive, dedicated, participatory, and I thank you very much. Have a great rest of the day, and we look forward to seeing you at church, June 8th at the Dominion Center, Old Hope Road, Dr. Eiffel's Church, where we'll start our Emergency Medicine Week. Thank you again, Professor Levy. Thank you, Professor Williams Johnson, for entertaining and educating and informing us. And I'm hoping that we can find better solutions to our most challenging problem of overcrowding in the ED. Thank you again, everyone, and have a great rest of the day.
Take care, guys. So good to see everybody. Be well.
Thank you.